So for everyone here, I would like to welcome you all to the Canada Fetal Alcohol Spectrum Disorder Research Network's webinar, FASD Research in Action, Sterling Clarren Award recipient. Here we will present this year's award and hear about the winning research project from the award recipient herself. Thank you all for joining us today. I'm just going to continue to, as we keep going, we'll let people keep joining. Oh, look at that. I see lots of folks adding in. Thank you, guys. I am Jacqueline Pye. I am the Senior Research Lead with the Canada FASD Research Network, as well as the Intervention Network Action Lead for the network. I'm really excited to be here today and super excited to hear your presentation, Danielle, I have to say. Before we jump into that, I just want to note that an important step in Canada and for CanFASD and reconciliation is the acknowledgement of traditional treaty lands and recognition for the people of the territory. The Canada FASD Research Network recognizes the historical significance and contributions of Indigenous peoples and their cultures, and understands the important role that the Indigenous community plays today and in the future. We acknowledge that we live, work, meet on traditional territories across Canada of many of the First Nations, Métis, and Inuit, whose footsteps have marked these lands for centuries. So the Sterling Clarren Research Award. This started with CanFASD wanting to engage new researchers exploring FASD and to give a platform to acknowledge some of the most promising emerging work in the field. The board of directors set up a research award and chose to name this award after the first CanFASD CEO and scientific director, Dr. Sterling Clarren. As many of us are well aware, Dr. Clarren has made significant and lasting contributions in FASD research, clinical work, policy, and good practice. Much of his work is the foundation of which we build on today. I know, speaking personally, that it's a rare day when I don't have Sterling's words echoing in my head around one thing or another that I'm doing. So he's deeply inspiring to many of us in this field as we pursue this work. We are very privileged to have Dr. Clarren with us today to speak about the important work of our recipient. Speaking of, I would like to introduce our award recipient, Danielle Johnston. Danielle is an occupational therapist who has worked with Alberta Health Services for 19 years. For 14 of those years, she has worked on the Camrose Pediatric Specialty Clinic, a diagnostic clinic which assesses children for a variety of conditions, including fetal alcohol spectrum disorder. She's currently pursuing a PhD at the University of Alberta in rehabilitation sciences, focusing on diagnostic accuracy of motor assessment tools used during fetal alcohol spectrum disorder evaluations with children. I'll now pass it over to Dr. Clarren to share a few words before Danielle starts her presentation.
Hello, everybody. It's great to be back. I was surprised and greatly honored when this award was named after me. And I didn't expect at the beginning that it would be so much fun to re-engage with the network every year over reading the papers that come past our desks and then hearing these presentations. This year is very exciting, both to me and to the other Dr. Clarren, Dr. Sandra Clarren, my wife. You know, the point of medical diagnosis is like the old Roman god Janus. Diagnosis looks backward to the etiology of the condition, and it looks forward to treatment. And in the center of that for us in fetal alcohol is the evaluation of the brain, which establishes that the patient has diffuse brain dysfunction and is a guide to treatment. When we started to develop that battery of tests, which was done largely by Sandy Sharon Beck and Heather Carmichael Olson, we all knew that occupational therapy evaluations would be an important bit. You just had to look at the kids to know that we should find something in that area. But it's been very elusive. And I've always wondered why until now. And as reading Danielle's work this year, a huge aha came to me, and I hope it will come to you. So everybody, let's sit back and listen to these new observations, which should prove very, very helpful in evaluating and treating our patients.
Thank you so much, Dr. Clarren. You see, his words are so wise. Appreciate that. Danielle, take it away.
Okay, well, good morning, everyone, or good afternoon, I guess, in some time zones. Thank you to Dr. Clarren and Dr. Pai for such a generous introduction. It's my absolute honor to be chosen as the recipient of the Dr. Sterling Clarren FASD Research Award this year. So to start things off, I'll just kind of tell you a bit about myself and my journey. As was mentioned, I'm an occupational therapist in Alberta, and I work on a pediatric diagnostic clinic. And one of the conditions we do evaluations for is FASD. I worked on the diagnostic clinic for approximately 15 years. And for years, I would say to one of my colleagues, like, we need to do research. We're sitting on a gold mine of data, and like, we need to use it. And she would agree, and we'd be all fired up, and we'd kind of look at each other and say, okay, so how do you do research? And it never really got off the ground because we didn't know where or how to start. So then a new program called the Research Challenge was started through our employer. And the program was geared towards clinicians and provided support and guidance to conduct clinical research. So as soon as I saw the email, I ran down the hall to my colleague and said, we have to do this. Like, this is kind of the missing link that we've been waiting for. So we applied, we got accepted, we completed the Research Challenge program, and we ended up publishing a research article on the topic of diagnostic accuracy in FASD evaluations. And as soon as we were done, we wanted to do a follow-up project. So our research mentors said, you know, if you're going to do another project, you really should do it formally and get formal training and credit for what you're doing, because you basically just completed a master's project. So 3-4 years later, here I am, and I'm currently a PhD candidate at the University of Alberta, and my research is in the field of motor assessment tools used in FASD evaluations for children. And all those years ago, when I would bug my colleague and tell her, you know, we need to do research, we were interested in research because we had noticed some things during the diagnostic process that didn't quite add up and we had questions about, and we were really wanting to know the answers too. So today I'm going to tell you about one of the studies we've had the opportunity to conduct to help us answer one of our clinical questions. The study is called a pattern of visual motor integration, visual perception, and fine motor coordination abilities in children being assessed for fetal alcohol spectrum disorder. So thank you for kind of adding to the chat who you are, where you're from. I see we have a lot of occupational therapists, and I see we have some other people as well. Welcome to everybody. I'm so happy you could join today. There we go. Okay, so I just wanted to take a minute or two to recognize the entire research team that contributed to this project. As with any project, it is not just done by one person, but an entire team. And funding sources include the Rural Health Professions Action Plan, or RPAP for short. So I'll start with a little bit about prevalence. FASD prevalence estimates vary widely between countries and different populations. The current estimate in the Canadian general population is 4%, making FASD one of the leading known causes of developmental disability. And I don't think that the prevalence in general is well understood. When I tell people, or people hear or find out that FASD is more common than autism, they are always surprised. At least that's been my experience. And the diagnostic clinic I work on evaluates children for multiple different conditions, one being FASD and another being autism. And I have had people say to me, so you chose to do your research in FASD and not autism? And part of the reason that I ended up going down the FASD route is because we had more clinical questions about FASD diagnostics than autism, but also because we know that prenatal alcohol exposure is underreported. We know that the FASD prevalence estimates are probably conservative, And we know that FASD is underfunded and under-researched. And so I wanted to be a part of the solution to those problems and help to serve this worthy and important population. So prenatal alcohol exposure, or PAE, can affect many different areas of the brain, contributing to a wide range of functional difficulties, meaning that each individual with FASD is unique and has a unique set of strengths and challenges, and that kind of the diagnostic profile is broad. Individuals with FASD are at higher risk for adverse life outcomes, such as school disruptions, legal issues, and substance use disorders. And early diagnosis has been identified as a key protective factor for avoiding those adverse life outcomes. So diagnostics are important. Misdiagnosis either way is something that we really want to avoid. Misdiagnosing an individual with FASD who actually does not meet criteria for FASD can lead to stigma. And diagnosing an individual as not meeting criteria when in fact they do can lead to the individual and family missing out on supports, funding, services, and interventions that can help support optimal outcomes for the individual and to support caregivers. So research really is needed to increase the accuracy and the efficiency of the assessment process, especially since the process is quite lengthy and pretty complex. So I will just give a little bit of information about diagnosis, which Dr. Clarren also talked to, which I appreciate. So for FASD, there's no like biomarker in the blood that we can test for, or something that we can use other types of diagnostic tools to detect, such as an X-ray or an MRI. When assessing a child for FASD in Canada, the Canadian FASD diagnostic guideline is followed. And the first step is always, of course, to confirm prenatal alcohol exposure. And then the second step is to evaluate the child's brain functioning to determine if the child has what's called pervasive brain dysfunction. Pervasive brain dysfunction is defined as 3 or more brain areas which are functioning at a level of 2 standard deviations or more below the mean. So this slide shows the areas of the brain that can be evaluated during an FASD assessment. If 3 or more of these areas are evaluated to be functioning at a level of 2 standard deviations or more below the mean, the individual would meet criteria for an FASD diagnosis. So as you can imagine, assessing all or close to all of these brain areas is a lengthy process, and it requires many different professionals. So the team that I work on consists of a pediatrician, a psychologist, a social worker, a speech language pathologist, a physical therapist, and an occupational therapist. And the families are typically with us all day for the assessment, and they fill out a ton of paperwork and protocols and questionnaires before they come. So it's a long day and a long process for the children and their families. Occupational therapists and physical therapists typically evaluate the motor domain. And today we're going to focus on the motor domain. So in the motor domain, fine motor, gross motor, visual motor integration, and graphomotor are all motor areas that can be assessed. And the Canadian FASD diagnostic guideline lists assessment tools commonly used in FASD evaluations. And I just wanted to take a moment to kind of reflect on the wording here. So the wording does not say recommended assessment tools. It is assessment tools commonly used in FASD evaluations. And my guess is that that specific wording was intentional, and it was used because that there isn't a lot of research to base recommendations on, which shows that research in this area is needed. And a survey of Alberta FASD diagnostic clinics published in 2019 showed that the motor domain out of all 10 domains had the least consistency in which assessment tools were being used, which also supports the need for research in this area. So we need to know more about which assessment tools are most relevant and accurate for FASD evaluations for children. And if you think about assessment tools, there are assessment tools for each of the 4 areas listed on this slide. And this is just one brain area out of the 10 that were listed on the previous slide. So there are a lot of possible assessment tools that can be used, and that leads to a lot of variability. One of the assessments listed in the Canadian guideline under the motor domain is the Berry-Bucktenica Developmental Test of Visual Motor Integration, 6th edition, or the Berry-6. The Berry-6 is regarded as one of the most valid and reliable instruments for the assessment of visual motor integration. It's frequently used internationally, both clinically and then also in research for assessment of children both with and without FASD. It's standardized, it's norm referenced, and it can be used with people ranging in age from 2 to 100. So super wide age range. The green booklet is the visual motor integration assessment and involves copying the shape in the top box into the box below. And it's the primary assessment. The blue and the brown booklets are considered supplementary assessments that help to assess the component parts of visual motor integration. So visual perception and fine motor coordination separately. The visual perception assessment is the blue booklet and involves looking at the shape in the top box and then pointing to the exact match from choices below. And it has a minimal motor component. And then the brown booklet is the fine motor coordination assessment and involves connecting dots while trying to stay inside of the lines and has a minimal visual perception component. And as discussed, the Canadian guideline lists the Berry-6 as a commonly used assessment tool, but use of the supplementary assessments are not specified. So the visual perception booklet would not be appropriate as an assessment tool for the motor domain, as there's no motor component, but the motor coordination booklet would be appropriate. So typically clinicians will either administer only the visual motor integration booklet, the green one, or all 3 booklets. Usually not just 2 are administered, and that complies with the Berry manual instructions to maintain valid results. And I personally always like to include the visual perception piece because it's often an area of strength. And I think we need to talk about strengths more often, especially in diagnostics. So visual motor integration is thought to be a more sophisticated skill than either visual perception or fine motor coordination alone, based on the premise that the act of integrating the 2 skills is more complex than performing them independently of each other. And it's been suggested that visual motor integration scores will be lower than the visual perception and the fine motor coordination subtest scores. And sometimes to be efficient, clinicians administer the visual motor integration assessment. And if the score is higher than the clinical cutoff, the assumption is made that the visual perception and the motor coordination ability scores will also be higher than the clinical cutoff. But clinically, when we were doing all 3 booklets, we were noticing that the children we were evaluating for FASD often had the most difficulties with the fine motor coordination subtest, and wondered if children with prenatal alcohol exposure may have a different pattern of abilities in these 3 areas than the general population. So then the aim of this study was to describe the visual motor integration, visual perception, and motor coordination pattern of abilities in children with prenatal alcohol exposure being assessed for FASD. So I hope I've been able to paint a bit of a picture of what an FASD diagnostic evaluation entails, at least briefly, and the importance of diagnostic accuracy. And now I'm going to tell you a little bit about the actual study. So the study was a cross-sectional study, and it was a secondary analysis of an existing clinical database previously used for research, which means that we didn't have to go back into the files and pull out the data we needed. It had already been entered into an electronic database, and that, I have to say, was super helpful and slick. The database was from the diagnostic clinic that I work on and included data from consecutive children assessed for FASD between 2010 and 2017. The age range of the children was 6 to 17 years at the time of assessment, and data from 134 children reviewed, and then 91 files were eligible for inclusion. So records that were excluded from the study were if the child had a genetic or a neurological disorder that precluded a diagnosis of FASD. The most common reason is if the file did not include all 3 Berry-6 assessment results, or if prenatal alcohol exposure was not confirmed. So statistics were calculated for 3 different groups. The total group included children with prenatal alcohol exposure, both who met criteria for diagnosis and those who did not. And this group was called the full sample. And from the full sample, then 2 subgroups were formed. The FASD group, which included children with confirmed FASD, and then the PAE group, which included children with prenatal alcohol exposure who did not meet criteria for a diagnosis of FASD. In the full sample, there were more males and females in all of the groups. However, the ratio of males to females was much higher in the FASD group and the full sample compared to the PAE group. And then the mean age for all 3 groups was almost identical at approximately 10 years, 6 months of age. So mean scores on the 3 assessment tools were calculated and then compared. And all 3 groups demonstrated the same pattern of abilities: highest ability in visual perception, followed by visual motor integration, and then the weakest abilities on fine motor coordination. So if you look at the kind of really light blue column, the FASD group, you can see that the visual perception score was 31.3, that's the percentile. And then below it is the visual motor integration percentile at 17.5. That was kind of the middle score. And then the lowest was 8.9 for the motor coordination subtest. And that pattern was repeated with the PAE group and then the full sample as well. This slide shows, it's actually the exact same slide, it's the same numbers, but just kind of a different way to look at it then. And that's because another pattern, like a really clear pattern, kind of emerged from this data. And that is that on all 3 assessments, the PAE group had the highest mean, and then the FASD group had the lowest mean. So this time, if you look at the blue row, you can see if we start with the middle column, the PAE group, the percentile score was 46.2, and then the full sample was 35.9, and then the lowest average percentile score was the FASD group at 31.3. And again, that pattern was the same for the visual motor integration booklet and the motor coordination booklet as well. So this may indicate that children who have been exposed to alcohol but do not meet criteria for FASD may be less affected than children who meet criteria for an FASD diagnosis, which really is not that surprising of a finding, but it is nice that it was really consistent. This is kind of just another way to present the same information, but in a more visual format for our visual learners. This shows that the mean percentile scores for the full sample were the highest in visual perception, represented by the blue bar, lowest in fine motor coordination, represented by the yellow bar, and that the visual motor integration abilities were in the middle, and they're represented by the green bar. And again, I just wanted to highlight the visual perception scores on this slide. In diagnostics especially, there's often a lot of talk about the low scores, because those are the scores that contribute to the diagnosis. But it's also important to recognize the high scores and strengths and abilities. And clinically, we often see that visual perception as an area of strength in the children that we're evaluating for FASD. So we also wanted to look at the data in a slightly different way. And instead of looking at the mean or the average percentiles, we went through the data from each child and made a note of which subtests they scored the lowest on. And approximately half of the children in the FASD group, so 57%, and approximately half of the children in the PAE group at 46% in this study were found to have the most significant challenges with motor coordination. So after the descriptive statistics were calculated, we wanted to determine if the differences in the mean percentile scores between the 3 assessment booklets were statistically significant. So Kolmogorov-Smirnov values were calculated to determine normality. And the underlying assumptions of normality were actually found to be violated. So we used the Friedman test as a non-parametric equivalent of a one-way within subjects ANOVA to compare the mean percentile scores. Post-hoc analysis, we used a Wilcoxon sign rank test to determine between which assessment differences were present. So this slide shows the results of the Friedman analyses. P-values, which indicate significance levels, are typically 0.05, but we adjusted the significance level because there were multiple comparisons. And that adjustment is called the Bonferroni correction method. So instead of the usual 0.05, the significance level was set at 0.017. P-values are significant on this slide if they are less than 0.017. So the Friedman analysis showed a significant difference was found in all three groups in assessment scores across the tests, and those values are shown in red on the slide. The post-hoc Wilcoxon analyses were then conducted to show us where the statistically significant differences were found. And as the slide shows, significant differences were found between all three possible combinations of tests for all three groups, with the exception of the analysis between fine motor coordination and visual motor integration in the PAE group, which is highlighted in red. So this slide is actually the opposite of the last slide. All the black values are statistically significant, and the one red value is the only value that was not statistically significant. So what do these findings and numbers mean? This study suggests that children with FASD and children with PAE have a different pattern of abilities of visual motor integration, visual perception, and fine motor coordination ability than the pattern suggested for the general population. It suggests that fine motor coordination tasks are more difficult for children with FASD and children with PAE, while in the general population, it appears that they have more difficulty with the visual motor integration tasks. And the next kind of logical question is why? Why is it that children with prenatal alcohol exposure seem to have a different pattern of abilities compared to the general population in these areas? And the reason remains unknown. But when looking at the literature, studies looking at the effects of prenatal alcohol exposure on brain structures have found that all regions of the brain can be affected. However, the occipital lobe in particular has been found to be relatively spared. So there have been multiple studies that have reported no significant findings in regards to differences in volume or shape or displacement of the occipital lobe when comparing brains of individuals prenatally exposed to alcohol with individuals who are not. And the occipital lobe is the visual processing area of the brain. The cerebellum is associated with movement. So if the occipital lobe is less affected by prenatal alcohol exposure than other areas such as the cerebellum, perhaps prenatal alcohol exposure affects the cerebellum more than the occipital lobe, and the result is enough to kind of upset the traditional pattern, and the visual perception abilities kind of emerge as a strength. So significance, why does this matter? So this is important for diagnostic clinicians to know, so they realize the importance of including fine motor coordination assessment in FASD evaluations for children. And ultimately, the reason why we want assessments included in FASD evaluations that show areas of challenges is to make sure that diagnoses are reliable and accurate, so that the individuals being assessed are correctly deemed as having FASD or not having FASD. In this study, 20% of the entire sample and then 25% of children diagnosed with FASD had scores that were below the second percentile in fine motor coordination, but above the second percentile on visual motor integration. So if this group of children had been assessed in visual motor integration abilities only, all of the children in this group would have been deemed as having abilities higher than the clinical cutoff, and these scores would not have been used as evidence towards an FASD diagnosis. So not including the fine motor coordination portion of the assessment could have affected the accuracy of the diagnoses in this study. In addition, diagnostic clinics typically don't just provide a diagnosis, right? But usually recommendations for supports and services based on strengths and weaknesses identified during the assessment. So by skipping over an assessment that identifies a commonly impaired functional deficit, the opportunity to recommend strategies and interventions to mitigate the functional deficit could be missed. Conducting research that will help provide evidence as to which assessment tools are most accurate for the diagnosis of FASD will help improve accuracy of diagnosis. Diagnoses are important because they are often the key that opens the door for children and families to connect with supports and services. It is well documented that an early diagnosis is strongly correlated with optimal outcomes for children with FASD. An accurate diagnosis allows children and families to put in place appropriate resources and supports for their child, advocate for their child, and to access interventions targeting areas of functional need. So basically, kind of what Dr. Clarren had alluded to at the beginning is that diagnosis really does kind of create a map for starting out recommendations for interventions and supports that are put in place. So if there's inconsistencies or difficulties in the assessment problem, it really does kind of trickle down to functional recommendations for the family and the child. And we don't want those to be missed or inaccurate for the child. We don't want the child in intervention for something that they don't need intervention for, and we don't want them to not be getting intervention for something that they really could be having assistance with or getting support for. So that is kind of the meat and potatoes of the significance of this project. And I am at questions and answers.
Thank you, Danielle, so much. What a fantastic and interesting presentation. I think, all of us can agree that the better we get at being, sensitive and specific in our diagnostic practices, as we started out talking about, the better. And, as somebody who lives in an intervention world a lot of the time, the better the information at that time point is, you're right. Like, we can do so much more to effectively map our intervention supports when the information is specific and really sensitive. So gosh, that was wonderful. Thank you. So I've got questions coming in, but I also am gonna, just because I'm gonna ask a question, and then I'll see if Dr. Clarren also may have one. But mine is just kind of a curious question, because as a clinician who sometimes does research, I have to just ask, did you find that the results you got just sort of validated what you already kind of thought? Or did you find yourself going, oh, that actually kind of surprised me? Like, I've had both experiences. I'm just wondering what your experience was in this work.
I have also had both experiences where, a previous project, I was almost disappointed with the results, because I was like, oh, that's not what I expected. And my research mentor said, you never get disappointed about the data. The data is the data, and it's showing you what it's showing you. But yeah, it wasn't what we expected. And then this project, I will say, yes, it was what we expected. It was. And like you say, it was validating, because in the manual for the BERI, it's pretty clear that the visual and motor integration scores are supposed to be lower. And so that was confusing, right? And so this was nice to kind of validate what we were seeing, and, oh, well, maybe it is the specific population that we are working with, that it's just different. So
yeah. And I've seen a couple of comments in the chat as well, indicating that others have felt similarly. So yeah, that's really interesting. Dr. Clarren, I'm just going to pass it to you, and then I'll turn to the question box. So folks, pop your questions in there if you have any. Oh, you're on mute, Sterling.
Boomer error. Thanks, Danielle. I think this is exciting for a couple reasons. One is this is interesting and potentially really helpful. The second is you're using our data set. And we always hoped this data set would actually give useful, interesting information. And so this is just a terrific example of what you can do by actually looking at what our patients teach us. And thank you a lot. With that said,
Again, thank you everybody for joining us today. Thank you and congratulations to Danielle, and thank you to Dr. Clarren and your time here. We know how much we appreciate and feel inspired by the work you've done. So thank you everyone, and look forward to seeing you next time. Bye-bye and happy Friday.
Thanks, everyone.